Secretariat, can we have the volume down, please? Good morning, ladies and gentlemen. This is just a wake-up call to all of us. I know I said we will start on time at 9 o'clock. However, the RD has given you all 4 minutes. So we will start right on 9:05. Thank you.
Madam Chair is still human.
Good morning, everybody. My apologies, we will start right on 9:03 a.m. Ladies and gentlemen, mabuhay, and a very good morning to all of us, especially to those that really enjoyed the entertainments last night and took part in all the entertainments. I think we all agree that it was a very, very warm night for everybody, and everybody enjoyed each other's company. At this time, we would also like to acknowledge online with us our Director General, Dr. Tedros. We understand it's 3 a.m. in the morning, so he has greatly offered his time to join us this morning. Before we hand over to Dr. Tedros to deliver his remarks, distinguished representatives, before we resume the rest of the agenda, draft resolutions have been uploaded on the Regional Committee web portal. And if any member state would like to submit an amendment to a particular draft resolution following our discussion of the agenda items, please submit your suggested amendment by email to the RCM email address. In suggesting an amendment, please use precise language. Distinguished representatives, ladies and gentlemen, it is now my great pleasure to introduce Dr. Tedros to deliver the Director General's address. Thank you, Dr. Tedros. Over to you.
Thank you, Your Excellency. Can you see me? And can you hear me?
Yes, we can hear you and we can see you clearly. Thank you.
Thank you so much. Honorable Minister Rose Toki Brown and the outgoing Chair, Honorable Minister Muhammad Isham Jafar, Regional Director Dr. Saya Piukala, Honorable Ministers and Heads of Delegation, Excellencies, dear colleagues and friends. Good morning, and I apologize that I cannot be with you in person. I just came back from Rwanda. As you know, there is a Marburg outbreak in Rwanda, and that's why I couldn't join you in person. And I congratulate the Regional Director on his first report, which paints a comprehensive picture of the region's work over the past year. There are so many encouraging signs of progress in the report and in the various progress reports that you will review this week. You have many achievements of which to be proud, especially in disease control. The Mekong Malaria Elimination Program is a standout success, driving a more than 90% reduction in cases and a 70% reduction in deaths over 6 years in Cambodia, the Lao People's Democratic Republic, and Vietnam. I also congratulate Vietnam for being verified for the elimination of trachoma, which you will celebrate together today. Many member states have made progress towards eliminating other neglected tropical diseases, including leprosy, lymphatic filariasis, rabies, schistosomiasis, and yaus, along with school deworming programs and water sanitation and hygiene initiatives. In your fight against NCDs, I congratulate Cambodia for banning marketing of alcohol near schools and at sports events, Cook Islands for passing new tobacco control legislation, Fiji for raising taxes on tobacco, alcohol, and sugary drinks, Lao PDR for implementing plain packaging, Malaysia for banning the sale of e-cigarettes to children, and the Philippines for the Healthy Hearts Program, which has achieved high rates of hypertension control. On emergencies, I commend the regional office for its effective response to the increasing number of dengue outbreaks in the region and to this year's Dut in Mongolia. We should all be grateful that the region has been spared the number and scale of emergencies that other regions have faced in the past year. But you have been far from idle. I commend member states supported by the regional and country offices for the hard work you have done on emergency prevention and preparedness by strengthening lab capacity, establishing national emergency medical teams, and through IHR self-assessments and joint external evaluations. As you know, at this year's World Health Assembly, member states made significant steps towards strengthening health emergency preparedness, prevention, and response. The adoption of a set of amendments to the international health regulations and the agreement to conclude negotiations of the WHO pandemic agreement before next year's assembly or sooner are major achievements. Although member states have made progress on the pandemic agreement, some of the most crucial issues remain unresolved. I urge all member states to continue listening to each other within the region and beyond, to continue to seek common ground, and to conclude a strong agreement by the end of this year, if possible. And I know it's possible to conclude the agreement this year. It's in your shared interest to do so. Excellencies, despite your many achievements, you face many challenges, which are also reflected in your agenda. Like many regions, the Western Pacific has seen significant improvements in health service coverage, but worsening financial protection. So I welcome the draft regional framework for health financing with its 5 action domains on public funding, more equitable and efficient spending, primary health care, governance, and economic and social policy. Another key challenge for the region is realizing the potential of digital health, which is largely untapped in many parts of the region. So I likewise welcome the draft regional action framework on digital health and its 5 action domains on governance, infrastructure, finance, digital solutions, and data. The 3 panel discussions on primary health care, oral health, and climate resilience are also good opportunities for member states to share experiences on key issues. Meeting all these challenges requires a strong, clear plan. So I commend Dr. Saya for his new vision for the region, weaving health for families, communities, and societies. This new vision sets clear priorities for both member states and the region and country offices supported by headquarters. I look forward to seeing the 5-year targets that you set together. These priorities are well aligned with the 14th General Program of Work, which member states adopted at this year's World Health Assembly. GPW 14 incorporates lessons from the past, the realities of the present, and our aspirations for the future. It's based on a clear mission to promote, provide, and protect health and well-being for all people in all countries, and to save 40 million lives over the next 4 years. To support the implementation of GPW 14, we have launched the first WHO investment round, which aims to mobilize the sustainable and predictable resources we need to do our work. We look forward to your participation at today's investment round event. Of course, we well understand that member states expect a strong return on investment from the resources they entrust to WHO, and so they should. We are committed to continuing the journey of transformation we began more than 7 years ago to make WHO more effective, efficient, transparent, accountable, and results-oriented. One of our key priorities now is to strengthen our country offices to provide more predictable, more stable, and more tailored support to member states. I'm pleased that WHO country representatives have been empowered through greater delegation of authority, along with enhanced capacity and positions in country offices to meet member state needs. Excellencies, dear colleagues and friends, I leave you with 3 requests. First, I urge all member states to engage actively in negotiations for the pandemic agreement and to complete it by the end of this year. And second, I urge all member states to implement the 14th General Program of Work and the new vision for the region set out by my brother, Dr. Saya. And third, I urge all member states and partners to participate in the WHO investment round. Thank you all once again for your commitment to promoting, providing, and protecting health for all people of the Western Pacific. And Honorable Minister Rose Toki Brown, back to you. And thank you for this opportunity. And thank you for allowing me to join you virtually. Although, as I said, sorry that I couldn't be in person with you. Thank you so much, and back to you.
Thank you very much, Dr. Tedros, for joining us online as it is very early in Geneva. And I must say that you have missed out on a very, very good night last night. Dr.
I will
Tedros,
come.
it was a non-alcoholic party, but everybody, we're all drunk on coconut drinks. But please do look after yourself, Dr. Tedros. You do a lot for nations, so take care and all the best.
Thank you. Thank you.
Ladies and gentlemen, as you all know, that since the Director General is not here in person, So we will not take interventions on this item. Now we move on to item number 4, the address by the incoming chairperson. Oh, that's me. Now I will make my way. Honorable ministers, distinguished representatives, Dr. Tedros, our WHO Director General, and your assistant, and all your hardworking team, to Dr. Saya, our WHO Regional Director for the Western Pacific region, your DPM, and all your hardworking team, all representatives of agencies of the United Nations, intergovernmental organizations, and non-governmental organizations, ladies and gentlemen, kia ora ana tātou katoa, I te aroa rānui o tō tātou atu, ko Iesu Mesia. Ko ia ka tika ia tātou ārawe, kia putu mai, I raro I te maru, o te ngutuare, e te enua, te Pasirea, for the Philippines. I greet you all in the name of our Lord and Savior, Jesus Christ. We thank the Lord for his mercy and protection on each one of us, allowing us to meet together here and on this country of Philippines. As my first time to take this platform, I would like to start with a traditional challenge from my home island of Attu in the Cook Islands. And it says, "Tututu matitike ka rokoia koe te pōkino, po tapu e aitu e ara, ai koko." And this translates, for us to be always on alert, for the nights of distress and some nights of peace will be upon us. So therefore, be awake and be vigilant. As health leaders, with all the many health challenges affecting our people, we experience many nights of distress and some nights of peace. No matter what comes our way, we must remain awake and continue to be vigilant. And my forefathers also once said, "Kia tawiri te pirita I tō ōrima, mō I tāu, e tangata tūke awa I ki pō." May the veins of thy hands grow stronger. Therefore, stand your ground like our warrior awa I ki pō. I also quote from Philippians. Paul in Philippians chapter 2, verse 2 says, "Then make us truly happy by agreeing wholeheartedly with each other, loving one another and working together with one mind and one purpose." So I thank you all once again for your trust and confidence in electing me as a chairperson of the 75th session of the Western Pacific Region Committee. I am honored, and I thank you all for making my work starting yesterday. You have all helped me to achieve. A hard day's work yesterday was completed, and we all did it together. So thank you. And I also look forward to another smooth proceedings today and the rest of the week. May I also thank our outgoing chairperson, the Honorable Minister of Health, Brunei Darussalam, and all office bearers, office holders of the last session. Thank you all also for your leadership. And I also acknowledge the support of my government and my people of the Cook Islands. Most importantly, I acknowledge and I thank my people of Inuamanu, my homeland of Atiu. To my electorate, the Inui and Mapumai, me takiranu nui no tā koutou turu I aku. E pērā tōku kopu tangata kaha totoa. I thank you all, my electorate, and all my families for your continuous support. If not for you all, I would not be standing here today. So, ladies and gentlemen, I am grateful to be working alongside our Vice Chairperson, the Vice Minister of Health, Professor from Vietnam, and our rapporteurs from China, Philippines, and France. This is a very special year, with it being the first regional committee meeting with our new regional director, Dr. Saya Piukala, at the helm. We have a lot of very important ground to cover, and your leadership have to be commended within the last 9 months. We see and we feel the new spirit amongst Wipro and all member states. Just an island boy, and here you are today, leading our region. And yesterday, we were presented with our new draft vision, weaving health for families, communities, and societies in the Western Pacific region. The vision using the metaphor of a mat to visualize all of us coming together only for one purpose, and that is to improve the health and well-being of all people that make up our regions. And last night, we saw some very amazing and interesting performances that our member states have already incorporated the vision using the mat. The displays that we saw last night, they were all amazing. And this week, let us all come together and weave a successful session of this regional committee with a positive and productive deliberations. We have a very busy agenda, including 2 technical agenda items and 3 panel discussions, as well as a number of side events. The first technical agenda item is health financing for youth, universal health coverage, and sustainable development. A draft regional action framework has been developed to support member states in strengthening the design and implementation of health financing policies to achieve health for all. While countries in the Western Pacific have made considerable strides in improving service coverage and population health, the number of people facing financial hardship when accessing healthcare continues to rise. And in addition, the capacity and financial sustainability of our health systems are increasingly stretched due to a growing NCD burden or a war against NCD. So addressing these challenges requires firm actions to strengthen the financing of health systems, but it also requires us to extend our vision beyond the health sector to promote health for all as a central goal of countries' broader development ambitions. We cannot do it alone. This is a whole of society approach. And the second technical agenda item is on digital health. The use of digital health solutions is growing at unprecedented pace in the Western Pacific. Telemedicine services in remote settings are increasing access to healthcare. Electronic health records are facilitating better informed and more efficient patient care. Mobile health apps are enabling individuals to take ownership of their own health. However, such big changes bring about new challenges. The 2018 Regional Action Agenda on e-health needs to be renewed to meet the needs of today. Hence, an agenda item on digital health is opportune at this juncture. The Regional Committee will be invited to endorse the Regional Action Framework for Digital Health in the Western Pacific. Yesterday, recognizing that climate change poses an enormous threat to the people of the Western Pacific region, impacting access to quality of healthcare services. The panel discussion on climate resilience in healthcare facilities showcased success stories from our member states on increasing resilience and adapting to a changing climate. 2 years ago, the 73rd Regional Committee endorsed the regional framework on the future of primary health care in the Western Pacific. And today, a panel discussion on transformative primary health care will address how aligning health systems to the primary health care approach remains critical in countries to achieve universal health care and the Sustainable Development Goals. So we continue to work together to create policy space through high-level dialogue and ensured a platform to operationalize the primary health care. And tomorrow, another panel discussion on oral health care will address the significant burden of oral diseases in our region, where over 800 million people are affected. And this session will reaffirm our collective commitment to strengthening oral health care governance and research by engaging families, communities, and schools in oral health initiatives to promote lifelong oral health and prevent diseases. And we all know it's a whole of society approach. Ladies and gentlemen, we have an exciting and a very busy week ahead of us. I know that all of us are committed to the health of our region. And I know that you all agree on the value of us convening here as members of the World Health Organization. Since our previous regional committee in 2023, the World Health Organization has launched its first investment round. And this initiative aims to secure the necessary, predictable, and flexible resources for WHO's core work over the next 4 years and will culminate at the G20 Leaders Summit next month. And that will be chaired by Brazil's President Lula da Silva. And the success of our new region missions relies on the mutual accountability of member states and WHO. And at a special event in this room today, ministers and officials will have a platform to showcase their commitment to WHO and the investment round. And I am pleased to learn that some exciting pledges of support are already planned. And we also heard our RD last night. During his performance, he was also reminding all of us that he is our son, he is our brother. And when I come for support, don't turn away. Help him. So we look forward to that. And during the deliberations, we've already seen the enormous support and commitments made by our colleagues and all distinguished representatives. So we look forward to all of this and more. And I thank you again for your confidence in electing me as chair. I thank my two brothers from Malaysia and Australia for also supporting, and everybody, all of you, my brothers, my sisters, my fathers and mothers, thank you very much. In closing, let us all work together with one mind and one purpose. And that purpose is to achieve health for all so that no one gets left behind. I leave you with one small wise saying from my island. Nō reira, kia kātō rama e toki tarai enua I te aratakianga I tō tātou its tangata. Let your light shine and your tool sharpened to pave the way in leading our nations and our people forward. And that's for you, our regional director. So may God bless us all. Kia ora ana e kia manuia. We will now move to agenda item 8 on the program budget. And you should all have before you documents WPR/RC75/3, RC75/INF/1, Program Budget 2022 to 2023. Budget performances, final report, and Program Budget 2026 to 2027, respectively. And may I now request Dr. Susan Mercado, Director, Program Management, to introduce these agenda items. Thank you.
Thank you, Madam Chair. Distinguished representatives, I am pleased to present Agenda Item 8 on Program Budget Matters, Item 8.1, the final report on the program budget for 2022-23, and Item 8.2 for the program budget 2026-2027. The first item, document WPR/RC75/3, is the final report on the performance and utilization of program budget 22-23 by strategic priorities and outcomes, budget centers, and categories of expenditures. The region's overall utilization of funds from all sources for the period covered was 316.8 million, or 93% of the total available resources of $340.6 million. The region continues to place a strong emphasis on the allocation of funds to country offices, as was the case for 2020-21 biennium, and 2/3 of the funds in 2022-2023 were utilized at the country office level. The region prioritized the implementation of base program activities, accelerating progress toward the triple billion targets and those of the Sustainable Development Goals as priority. Building resilience by strengthening primary health care and bolstering response capacities to health emergencies were also priorities for the period covered. As of 31 December 2023, all internal and external audit recommendations had been fully implemented, with no audit report or observation outstanding for the region. Likewise, great progress has been made on audit reports issued this year. The region is on track to implement these recommendations by the end of 2024. The Secretariat continues to improve controls through strengthened management, training and staff clinics, improved communication, reviewing of performance dashboards, and monitoring of high-risk exposure transaction areas in the region, specifically the Direct Financial Cooperation or DFC contracts. Award management, goods, service procurement, asset inventory management, these are all subject to improvements and reforms through our administration. Gender balance and geographic distribution of the staff also continue to be priorities. Significant progress in gender parity has been made through recruitment policy adjustments and increased awareness raising among staff. As of December 2023, the proportion of female international staff in the region rose to 60%. We also continue to reach out to unrepresented and underrepresented countries to improve diversity, inclusion, and equity. The annex to document WPR/RC75/3 contains the performance assessment of the first year of program budget 22-23. Information on progress in achieving outputs of the WHO's 13th General Program of Work is contained in the annex to this document. So if you would like to see the details, please go to the annex, and there are a number of tables there that you can refer to. This is based on the end of biennium assessment covering January 2022 to 31 December 2023. Before we discuss the second agenda items, namely the proposed program budget of 2026-2027 that will be presented by our colleague from headquarters, I would like to share a brief update on the status of the program budget for 2024 to 2025. And typically, we don't make that report during the existing biennium. We actually report on it on the next or the end of the biennium. But for everyone's information and for transparency, The approved program budget is 430.2 million. As of September 2024, the program budget was only 53.6% financed, for a total of 230.7 million. The utilization rate for 2024-25 currently stands at about 50.3% of the available financing. But when compared to the approved program budget, it only totals 27%, with the overall utilization of $116 million. The region continues to work on strengthening implementation, although flexibility is limited by substantial percentage of financing that is earmarked, unpredictable, and unsustainable. The second agenda item that will follow immediately after my talk is item 8.2. The document is RC75/INF/1 on the proposed program budget for 2026 and 2027. This document was finalized in September of this year, after discussions also through the World Health Assembly, and it is why it arrived a little later to the member states. This was one of the last few documents we sent you. The proposed program budget for 2026-27 is the first to be fully developed based on the WHO 14th General Program of Work for 2025 to 2028, or GPW14. And just again, for transparency, we see 2025 as a transition year for GPW14. The last year, we were still operating under GPW13. GPW14 aims to advance health equity, strengthen health system resilience, building on the 13th General Program of Work for 2019 to 2025. The program budget also takes into account the increases in assessed contributions as approved by the member states in May 2022 at the World Health Assembly that has significantly helped our work in the World Health Organization. The Health Assembly noted that sustainable financing is essential for the community continuity and stability of the World Health Organization programs and for maintaining its capacity to respond to global health emergencies and challenges. And again, if you would like to look at the details of these are in the annex so that you could see what the gaps are. The development of the program budget has continued priority setting as an integral part of its development process, starting at the country office level to ensure maximum alignment and country needs and priorities. And again, in GPW 14, there is a very strong focus on climate and its impacts on health, which is really different from GPW 13. The country prioritization results are key to developing and implementing the draft proposed program budget. Inform budget costing, allocation of resources, and resource mobilization efforts, as well as determining what the human resource requirements are for the organization. A full draft of the program budget 2026-27 and its summary version, the August 2024 Regional Committee version, documents, again, RC75/INF/1. As in the approved program budgets of past biennia, the proposed program budget 2026-2027 is presented in 4 segments. These are base programs, emergency operations and appeals, polio eradication, and special programs. 2 scenarios are presented under the emerging operations and appeals segment. With your agreement, Madam Chair, I now would like to invite Mr. Emery Holo, the Director for Strategic Planning and Budget from WHO Headquarters, our colleague, who will now take the floor. Thank you, Madam Chairperson. Emery, it's yours.
Thank you very much, Susie and Madam Chairperson, distinguished delegates, RD. I'm here to present, as DPM explained, the draft proposed program budget 26-27. This is the first reading of the program budget that goes to the regional committees for their initial comments. Then after all the regional committees, we summarize and gather all the comments and guidance received, and we produce a new version, a revised version of the program budget document that is going to be submitted to the executive board in January in Geneva. Once that document is discussed, we will consider the guidance received from the executive board and from the other member states, and then we'll present the final proposed budget to the World Health Assembly in May. I'm just saying this because just want to make sure that you understand that this is a long process where you have ample opportunities to provide guidance and input into shaping the program budget document. And it will probably also change based on the information and guidance we receive from you, member states. Next one, please. So what is new about program budget 26-27? So as the DPM said, this is the first program budget which is fully based on GPW 14. Because 2025 is a transition year and it's still based on GPW 13. So this is the first program budget that uses the results framework and the indicator structures that is developed in GPW 14. We also looked at several evaluations of GPW 13 and incorporated that in the development of the program budget. We also understood that one of the criticism of GPW 13 and the program budgets underlying was that the indicators, the monitoring needs to be strengthened in order to better report to member states on the achievements. And this is what we're trying to do with the new GPW 14 and with the program budget that's presented to you. We also would like to make a strong link between the priorities that you member states set and the budget allocations that are reflected in the budget. And we would like to keep our commitment to fund those areas that you deem as priority, at least at 80%. And lastly, this program budget, just as the GPW 14 document before, was the result of very extensive consultation. And in the results framework and in the indicators, all the country offices have participated and provided comments and input, not only the regional offices. Next one, please. So in order to strengthen the measurement and the achievement of the results, there's a lot of work happening in the background, which is not fully yet represented in the draft proposal that you see. We're working hard on establishing baselines and targets for all the outcomes and all the outputs. And we hope that by the January version of the program budget, there's going to be much more detail in terms of these elements, particularly the output measurement that we will be able to present to you. Next one, please. As you know, and you have been involved, we have done a thorough prioritization exercise at the country level, led by our country offices and our heads of country offices. Many of them are here today. And this is the outcome of the first prioritization that came through globally. And it's interesting to see that there are 5 areas that come out very strongly from this prioritization exercise. The one is risk factors for NCDs and communicable diseases. The second one is primary healthcare. The third is equity in access to quality services. The fourth is preparedness, readiness, and resilience. And the fifth is health workforce. So these are the areas that came out as clear front runners when you said that you would like to work together with the Secretariat on these areas. And I just would like to point out that these priorities don't always represent the priorities of the countries. It is the priorities where you see there's scope to work together with WHO. So it could be slightly different from the overall priorities of the countries. Next one. When we turn to WIPRO, 27 countries in this region have already finalized this exercise. And there's a very strong alignment between the global results and the regional results. And 56 countries prioritized 2.2, 3.1, and 4.1. So risk factors, primary healthcare, and equity in access to quality healthcare as priority. And 31% of all outcomes were prioritized as high, which is very good because it shows that countries in the region have the courage to be selective in setting the priorities and not selecting everything as a top priority. Next one, please. So the regional results, which you see on the right-hand side, is very much aligned with the global results. 4 of the top 5 priority outcomes coincide the same as the global priorities. There's one which is not ununderstandable, which has made it to top priority in WIPRO and not yet globally, and that's related to climate change. And this is also what was reflected in DPM's remark. So this is a specificity for this region, but is very much at the heart of GPW14, and we were very glad to see that reflected as a priority here in WIPRO. Next one, please. Turning into the budget figures, can we move to the next slide, please? Yes. So turning into the budget figures, the proposed budget that we're presenting to you is based on the financial envelope that was developed for the GPW14, which is also the basis of the investment round. So for 4 years, we presented an 11.1 billion funding requirement for the 4 years of the GPW14. And if we translate that for 26-27, that brings the 5.5 billion base budget proposal that you have in front of you, which is basically a $550 million increase compared to previous biennium. Next one, please. Basically, there are a couple of issues that we need to discuss with the program budget, and as the DPM explained, there are 4 segments of the program budget, and one of the segments is the emergency operations and appeal segment. Here we're presenting to you 2 scenarios. One is based on a planned amount of 1 billion, which in the past proved to be too low. So the actual expenditures under this segment have been significantly higher. And as a result, we have been, our reporting have been a little bit distorted because we presented as if we were over implementing and have been over financed. And as a way to remedy that, the second scenario is presenting a more realistic planned amount for this emergency operations scenario, and that is 2.8 billion, which is based on the last emergency appeal that we submitted based on the needs. Just would like to reiterate that these, compared to the base budget, where you approve a budget and then you also approve the priorities and also in a way a spending and fundraising limit for the organization, when it comes to emergency operations, that's not a ceiling. It's not a limitation, because this segment is driven by the actual emergencies that happen and the requirements that needed for that. So this is really a planning amount that we can basically present for the sake of monitoring and reporting, but does not have that limitation strategic factor. Anyway, so we're presenting these two scenarios for you to advise us on whether we should move to a more realistic planned amount, but then it gives the impression that our budget had a huge increase, which in reality it doesn't. It just simply is a reflection of the actual emergencies, or we stay with the 1 billion, but then if the actual needs are higher, we continue to have problems with reporting. Next one, please. If we, going into the base budget, if we dissect the increase by major offices, you will see that all the major offices will see a substantive increase in their share. In the Western Pacific, it amounts to 13%. And the Western Pacific's budget will move from 408 million to 463 million. And then you can also see that in headquarters, we really try to keep the increase to a minimum. The numbers, how much every region is increased, is primarily driven by the country strengthening component of the increase. 387 million of the total 550 million underlying the proposed increase is related to strengthening country offices, and the strengthening of country offices is happening based on a categorization of countries, which is translated then into needs and positions that need to be strengthened. And that's why the biggest increase is happening in the Eastern Mediterranean region, because they have the most countries that require the biggest investments in terms of staffing and capacities. Having said that, I believe that this is a very substantial increase for the WIPRO region, and of course, this is a budget, so we will have to finance it as well. Next one. Just would like to say a word about output indicators and leading indicators. This is something that you don't see currently represented in the program budget, but we're working very hard in the background to make sure that the program budget 26-27 document will include indicators, baselines, and targets for the outputs. Just to say that in GPW 13, we only managed to do that at the very end, so the program budget 24-25 of the cycle. So in that sense, if we manage to do it already for the first budget of the GPW 14, it will be a big difference and improvement. Next one, please. As the DPM said, there's been a landmark decision in 2022 at the World Health Assembly by the member states, which set WHO on a more sustainable financing path. And this decision has launched, in a way, or asked the Secretariat to look at launching the investment round. And secondly, it has also foreseen an AC increase that needs to be done in this decade by the end of 29-30, and reaching 50% of the 22-23 program budget amount. So in that sense, the amount was locked. What this decision has done was it set out the major goal, the 50% of the 22-23 amount. It has set out the AC increase for 24-25, which was the 20% that we have already benefited from this biennium, but it has not set the road how the next AC increases should happen between basically now and end of the decade. So next one, please. So it is for us and for you to decide what is the underlying AC increase that should accompany the program budget 26-27. And what we have done with my colleagues and with the leadership of WHO, we looked at the timeline. If you recall, the WHA decision was not clear whether it's 28-29 or 30-31. So we said, let's use the longer time frame and let's set 30-31 where we reach the end goal. And we looked at what would be realistic increases that can deliver the 50% by the end of 31. And we wanted to basically choose the lowest amount for 26-27 that would still be realistic in terms of implementing the landmark decision 2 years ago. And this is basically 20%. We think that any lower amount would risk the implementation of the overall decision because it would require much higher amounts in the subsequent years that would not be probably realistic. So this program budget that you have in front of you is based on an assumption that you will approve a 20% increase of the SS contribution going into 26-27, which will be $229 million. Next one, please. So just to wrap up, there are 3 questions that we'd like to ask you to consider either today or as we go along in the discussions on the program budget. Are you in agreement with the draft figures of the program budget presented and the priorities that lie behind that? Which are the 2 scenarios for the emergency operation appeals that I presented would you support? And how would you like to move forward with the discussion on the AC increase? Thank you very much.
Thank you, Imre, and I'd like to turn back to our chair. Thank you, Madam Chair.
Thank you. Thank you very much. Now we will hear from our representatives who wish to speak on these items. And may I remind that the interventions on items 8.1 and 8.2 should be combined. And please indicate your wish to speak by clicking on the big button on your microphone. Thank you. I see New Zealand. Also, my apologies. Papua New Guinea, you may take the floor.
Thank you, Madam Chair, Regional Director, colleague, health ministers, esteemed delegates, ladies and gentlemen. Thank you for the presentations done by our budget team. And I'd like to, on behalf of the government of Papua New Guinea, pledge $60,000 as our commitment to the World Health Organization investment round. This pledge reaffirms our dedication to advancing global health goals and strengthening our collaboration with the WHO in addressing critical health challenges. Since its establishment in PNG in July 1976, just 11 months after our nation's independence, the WHO has been a steadfast partner to our journey towards improving health outcomes for Papua New Guineans. The presence of the World Health Organization country office within the same building as the National Department of Health in my country and the Minister of Health is symbolic of the close and enduring partnership we share. This proximity has facilitated seamless coordination and a unified approach to addressing the health needs of our population. Last week, we launched the country cooperation strategy between WHO and PNG, and implementation has already commenced. This strategy framework will guide our collaborative efforts over the coming years, ensuring alignment with national health priorities and global health standards. The strategy further strengthens our partnership, providing a roadmap for addressing key health challenges and achieving sustainable health outcomes for our people. WHO has provided a continuous support in response to numerous health emergencies and disease outbreaks in PNG, including polio, tuberculosis, and most recently COVID-19. This collaboration has been instrumental in strengthening our health system, building local capacities, and ensuring timely access to essential health care services across our country. As we look to the future, our government remains committed to investing in health as a cornerstone of sustainable development. We recognize that only through a collaborative action and strengthened partnership can we overcome the health challenges that face our region and the world. Our pledge to the WHO's investment round is a testament to Papua New Guinea's unwavering commitment to the health and well-being of our people and to supporting the WHO's effort to achieve a healthier, safer world for all. Thank you.
Thank you very much, Honourable Minister. Now we turn to our Honourable Minister from New Zealand. Thank you.
Thank you, Madam Chair. New Zealand appreciates the progress report and welcomes this early opportunity to review WHO's draft program budget for the next biennium. In the interest of time, I will focus my remarks mostly on item 8.2. Strong alignment between the program budget and the general program of work approved for 2025 to 2028 across the three levels of WHO structure, headquarters, regional offices and country offices, is critical to achieving the goals of health system resilience and health equity. It is pleasing to see the commitment to a results-orientated approach with clear indicators and benchmarks, including to measure WHO's technical work on gender equality, equity, sexual and reproductive rights, and disability inclusion. We look forward to seeing more on the proposed impact measurement system to track progress. Clear targets are key to improving performance and targets save lives. New Zealand welcomes visibility of the proposed budget for the next 2 years and the continued focus on ensuring that WHO has a sustainable financing base to deliver the things expected by its members. As I'm sure the Secretariat and colleagues around the room today will appreciate, developing budgets of this nature requires a sharp focus on priorities and a balance of being ambitious but also realistic. We note that the budget includes an increase in the percentage of member states' assessed contributions, stemming from discussions and decisions taken in 2022. Given the invitation for this information paper to prompt discussion here at the RCM, New Zealand will be interested to see various scenarios being utilised in further drafts of the budget, specifically with regard to the assessed contribution portion. New Zealand appreciates the WHO Secretariat's plan on reform, enhancing budget governance, transparency and overall accountability, as well as the continued emphasis on ensuring that resources and effort are predominantly directed to the country level. We look forward to further discussions with colleagues and WHO on the next biennium program and budget in the coming months. Ata mārie. Thank you.
Thank you very much, Honourable Minister. Now we will move on to our representative from the Republic of Korea.
Thank you, Madam Chair. The Republic of Korea thanks the Secretariat for submitting the drafted program budget 2022-2023, budget performance and program budget 2026-2027. With the program budget 2022-2023 budget program, we were able to see that the Western Pacific region has concluded the fight against COVID-19 pandemic, has been focusing its capacity on implementing regional frameworks, including the mid to long-term budget vision for the future, and has been making efforts for improving GPW13 indicators with the members and partners. We appreciate the effort for strengthening responsibility and transparency in planning and implementing budget, and the progress regarding the erasing of gender imbalance in the regional office and preventing and responding to sexual exploitation, abuse, and harassment. Meanwhile, the Republic of Korea considers that it has a great meaning that the regional committee started discussing the draft of program budget 2026 to 2027, which is the first budget proposal developed to implement the vision of GPW14. The Republic of Korea supports the idea of making sure resources are put in a place where they are most needed and where the biggest change can be brought about, which is the main idea of the drafted program budget 26-27. Also, we welcome the introduction of innovative methodology that involves result-centered performance evaluation, setting priorities in a bottom-up way, and setting priorities in resources in accordance with the risk management approach. We kindly ask for the Secretariat's continued interest in implementing the tasks for innovating WHO, which is for raising the efficiency of work. However, as the increase in the budget for the base program, $560 million, far exceeds the increase in the assessed contributions, $230 million. We cannot help but question the feasibility of funding the whole program this time. It was agreed at the World Health Assembly in 2023 to gradually increase the assessed contributions by 2030. But we need to note that we need voluntary contributions as well as the assessed contributions in order to fund the program in full for the 2 years. We asked the Secretariat for a detailed explanation on the outlook for the finance, including the progress in increasing the assessed contributions and the current state and the prospect of voluntary contributions. The Republic of Korea supports the efforts of the WHO Secretariat for predictability and flexibility of the finance, and Korea will continue to cooperate in order to resolve the issue of finance at the WHO. Thank you.
Thank you. Thank you, Honorable Minister. Now we move on to Philippines.
Thank you, Madam Chair. The Philippines notes with appreciation the final report on budget performance for the previous biennium 2022 to 2023, as well as the proposed program budget for 2026 to 2027 biennium. The program budget proposals should be genuinely anchored on the country's priorities and situation and localized to address local needs. We highly value the critical role of the WHO country offices, as well as the support provided by the regional office in ensuring maximum alignment with member states' priorities through timely conduct of robust country prioritization exercises. With this, we strongly advocate for the Secretariat at the regional and country levels to ensure allocation of ample time and resources for regular review and assessment of impact and alignment. This is an integral element of continuous monitoring and evaluation, centering on member states' needs and perspectives to allow prompt recalibration of implementation priorities based on our ever-changing situation in rapidly evolving times. We note the proposed increases in the base program segment, which benefit the country and regional offices, and are happy with the increases in the Southeast Asia and Mediterranean regions. We are hopeful for increases on the base program segment for the Western Pacific too, as we note the glaring gaps in the report on financing in the previous biennium, especially for health emergencies and universal health coverage. This reveals our own pockets of poverty and highlights the importance of our acceleration point on sustainable financing for the World Health Organization. In order to regain and sustain momentum towards health-related development targets, strengthen primary health care and build resilience and save lives. The Philippines, therefore, remains strongly committed to our collective will on increasing assessed contributions as a key intervention for sustainable financing and implementation to achieve the results that we want. We also underscore that the call for more flexible voluntary contributions so that together we can immediately address the pockets of poverty in WHO programs across and within countries and regions. Equity in access to services should always be a high priority outcome in our program budget so that we will remain faithful to the goal of leaving no one behind. Our success in achieving development goals and major health outcomes necessitates our solidarity as member states in driving public health impacts. This will need due consideration for different levels of health system capacities and ensuring equity at the core of global actions. Thank you, Madam Chair.
Thank you, Philippines. Now we move on to Cook Islands.
Thank you, Madam Chair. Regional Director, Honorable Ministers, relevant partners, ladies and gentlemen, Kia ora. I congratulate the WHO Secretariat for the Program Budget Biennium 2022-2023 Budget Performance Report and also the Draft Budget Program for 2026-2027. I also extend our sincere thank you to the support from the Regional Support Office. The Cook Islands has also been privileged and commend WHO for the technical and budget allocation during the 2022-23 budget round and support towards the Cook Islands nursing program together with SPC. As highlighted in the report, with the revitalization of the Healthy Islands initiative in the Cook Islands providing a significant stride towards a comprehensive health promotion and disease prevention by focusing on enhancing health outcomes through improved living conditions, which this initiative aims to create environments where people can achieve maximum health potential. WHO's role in this effort was multifaceted, involving the development of strategic plans, the facilitation of community engagement, and the provision of technical and financial resources. This approach, which targets schools, villages, and primary healthcare settings, emphasizes the importance of holistic health promotion strategies that are inclusive and accessible. The impact of these efforts on health outcomes is profound, contributing to the reduced incidence of NCDs, improved mental health, and enhancing well-being across our population. Also, this work is also supported with budget support through the passage of the new Public Health Act 2024, the Tobacco Products Control Amendment Act 2024, the review of the NCD Strategy 2021-2025, the Food-Based Dietary Guideline, the physical fitness guidelines, to name a few. The Kukans also acknowledge the support of UNICEF and FAO to these initiatives and the ADB WASH program. Again, thank you, WHO, for the budget program 2023, and look forward to the finalization of the budget program 2026-2027. Madam Chair, I thank you.
Thank you, Cook Islands. Now we move on to Cambodia.
Thank you. Thank you, Madam Chair. Cambodia welcomed the new WHO program budget 2026-2027. The first to be developed as a part of the WHO 14th General Program of Works. The new program budget reflects the commitment of the WHO to strengthen its presence at the country levels. Providing sustainable resources for the new program budget is needed for a stronger and more effective WHO that is fit to support the member states as they tackle increasingly complex interdependency between health threats. Cambodia also welcomed the gradual increase in access contributions that the member states agreed to in May 2022, and commend the ongoing efforts to provide flexible and predictable financing through the investment rounds. For the results to translate into impacts at the country levels, it is key to focus efforts where they can deliver the largest impacts. In Cambodia, the Ministries of Health and the WHO have worked closely to jointly prioritize the GPW14's outcomes in line with our new Cambodian WHO's Country Cooperation Strategy 2024-2028. As part of the program budget 2026 and 2027, we look forward to partnering with the WHOs to jointly deliver the Cambodian WHO's Country Cooperation Strategy 2024-2028, moving toward integrated approach, sustainable solutions, and impactful actions that can deliver health for all. I thank Madam Chair.
Thank you very much, Cambodia. We move on to Vanuatu.
Thank you, Madam Chair. Vanuatu thanks the Regional Director and his directors for the budget proposal. Vanuatu stands ready to support the Regional Director and WHO to deliver that budget allocation. For the draft program, budget Vanuatu would like to propose support not to only cover programs, but also infrastructures and refurbishment of health facilities. Also, Vanuatu would like to propose if WHO can review the DFC financial process to make it accessible for us to utilize in country. Thank you, Madam Chair.
Thank you very much, Vanuatu. Next, we have Vietnam.
Thank you, Madam Chair. Vietnam welcomes the result report 2023 as well as the financial statement for the year ending 31st December 2023. The result reports show that the global progress towards the 3 billion targets and sustainable development goals are currently get challenges, including for the 3 pillars under the WHO base segment, namely better health, universal health coverage, better health, emergency protection, and healthier populations. We attribute this trend to the complete challenges that are affected by resilience of the global health system, including climate change, increasing global conflict, war and insecurity, emerging infectious disease outbreaks, as well as health workforce fatigue and disruption of health service delivery. Vietnam would like to call for solidarity and coordinated action among governments with WHO and other partners to promote, protect, and provide help for people around the world. Looking forward, Vietnam welcomes the draft proposed program budget for 2026 to 2027, which provide advancing health equity and strengthening health system resilience. We have to note that the total proposed budget for 2026 to 2027 is $7.7 billion under scenario 1 for the emergency operations and appeal segment, and $9.5 billion under scenario 2. The total proposed budget for 2026 to 2027 under both scenarios is higher than approved program budget for 2024 to 2025 of $6.8 billion. Vietnam welcomes the shift in WHO financing, with a larger proportion of the base budget expected to be financed by increasing assessed contributions and core voluntary contributions. We also take note the adjustment of the classification of thematic funds from specified to thematic in nature, allowing for greater predictability and flexibility in the deployment of these funds. This will enable WHO to accelerate the implementation and progress of program activities in an integrated, coordinated, and more efficient manner toward to SDG health targets. To support this further through joint efforts with WHO representatives office in Vietnam, we are finalizing the Vietnam and WHO Health Cooperation Program for 2024 to 2027. This followed by the government of Vietnam policy for managing overseas direct assistance as well as WHO operational planning guidance. On this occasion, we would like to sincerely thank WHO and other international development partners for the technical and financial support they have provided to our health system. We're looking forward to a fruitful collaboration with you in the coming years. Thank you.
Thank you very much, Vietnam. Ladies and gentlemen, my apologies for those of you that haven't taken your opportunity to make interventions. We will now suspend this item and have a break for coffee, and we will resume consideration of this item after lunch, following item 15.5, a membership in the region. Request for Indonesia to be reassigned from WHO Southeast Asia region to the Western Pacific. After coffee break, we will start the panel discussion on transformative primary health care. And during the break, may I invite my fellow Credentials Committee members, the Honorable Vice Chairperson, and the rapporteurs to join me and the Senior Legal Officer at room 208E to take up the work of the committee. And the plenary session will reconvene at 10:45 a.m. Thank you very much for understanding. Welcome back, honorable delegates. Now, I would like to report to you on the credentials for the meeting. The officers of the Regional Committee met today, this 22nd day of October 2024, to consider the credentials of representatives in accordance with Rule 3B of the Rules of Procedures of the Committee. The credentials of the following delegations were found to be in conformity with the Rules of Procedure as constituting formal credentials. Australia, Brunei Darussalam, Cambodia, China, Hong Kong, SAR, China, Macau, SAR, China, Cook Islands, Fiji, France, Japan, Kiribati, Lao People's Democratic Republic, Malaysia, Republic of the Malaysia Islands, Federated States of Micronesia, Mongolia, New Zealand, Republic of Palau, Papua New Guinea, Philippines, Republic of Korea, Samoa, Singapore, Solomon Islands, Tonga, Tuvalu, United Kingdom of Great Britain and Northern Ireland, United States of America, Vanuatu, Vietnam. The officers therefore propose that the Regional Committee should recognize their validity. I see no objections. It is so decided. We now move to agenda item 10. May I ask our representative from Vanuatu to please turn your name. Thank you. And Minister from Samoa. We move to agenda item 10, panel discussion on transformative primary health care. Document WPR/RC75/5. And I would like now to hand over to our Regional Director to introduce this item.
Thank you, Madam Chairperson, distinguished representatives. I'm pleased to present this item. Health systems in the Western Pacific region are experiencing extraordinary challenges. These include aging population and rising NCDs, significant fiscal constraints, and increasing vulnerability to health emergencies and environmental change challenges. Many health systems in the region are unable to handle these demands. They are still overly hospital-centric and not financially sustainable. Often they do not have the right mix of skills in the health workforce to address the needs of older people. These challenges, however, can also be the opportunities for countries to shift towards service delivery models that are adaptable, sustainable, and focused on achieving long-term health outcomes. The new WHO vision for the region advocates the integration of transformative primary health care into the lives of families and communities. This approach allows for more tailored actions to effectively control non-communicable and communicable diseases delivered using a range of platforms that includes traditional medicine and digital health technology. The Regional Committee in 2022 endorsed the Regional Framework on the Future of Primary Healthcare in the Western Pacific, which called for health system transformation to achieve universal health coverage and the health-related targets of the Sustainable Development Goals. The regional framework is a comprehensive, people-centered approach to health. It highlights strategic areas of action, including service delivery models, individual and community empowerment, workforce and service providers, financing and enabling supportive environments to transform primary healthcare. Primary healthcare is not just about treating diseases, it's about promoting the highest attainable level of health and well-being for all. It is the most inclusive and equitable and cost-effective way to achieve universal health coverage and reach the unreached. To achieve universal health coverage and the health-related SDG targets, countries need strong health systems focused on transformative primary healthcare. At the same time, primary healthcare strengthens the resilience of health systems, making them better prepared to respond to and recover from shocks and crises such as pandemics and climate change. The world officially recognized that primary healthcare is key to achieving health for all in 1978 with the Alma Ata Declaration. Now, nearly a half a century later, there is little evidence of concrete changes in most countries. The bottom line is that we need to change the way we are working. We need to move beyond discussions into sweeping actions. WHO is committed to supporting member states in this journey. Together we can overcome any challenges and build a future in which everyone, everywhere has access to good quality healthcare. It is our hope that this panel discussion will provide an impetus for sharing perspectives on transformative primary healthcare and how it can drive efforts to achieve universal health coverage and the Sustainable Development Goals. In the process, we hope to gain a greater understanding of the factors that have driven successful primary healthcare reforms, as well as the best practices for measuring and evaluating progress. Please welcome our panelists from the Ministry of Health of Cambodia and Singapore, as well as experts from the Asia Development Bank that are here this morning. We invite everyone to participate in this important discussion, and we hope that we'll active participation. And now I have the pleasure of handing the floor to Mr. Luis Vinal-Torres, the Director of Health Systems and Services, to moderate today's panel discussion. Thank you, and over to you, Luis.
Soon. Thank you very much, RD. Good morning, everyone. 46 years we are talking about primary health care, and we are still here trying to bring it back as our probably the most important or the centerpiece of WHO work in the region. As you saw yesterday, transformative primary health care is the first vertical strand of the new vision. And as RD said yesterday, it's not his personal vision, it's our collective vision. So why after 46 years, still we need to put emphasis and call for more action in primary health care? I'm going to run 3 slides to set the scene before we move to our distinguished panelists. What do we mean by transformative primary health care? Most probably, if I ask individually each of you, you might come with slightly different definition of what you think that it is or what your countries are doing. But one thing I think we probably could easily find a common ground of what are the features of the systems that you would like to see in your own countries. And this is just a few of them. We really want systems that do not wait for the people to get sick. We want that the systems proactively keeps people healthier. We also want that there is a permanent relationship between the provider and the people. It's not waiting and see. It is the provider takes care of the people of their catchment population. They know what the needs are. We know what the targets are, and we are working towards them. And the user knows who the provider are, and probably by name and surname. Because when it comes 3 years later, it's the same provider and we have my records. Another feature that probably you would like to see in your system is that there is one single information system, which is access everywhere and for everyone. And also your system, you also want to hear the opinions, the views, and the preference of your communities. And you also want that the user has an active role in the decision making. Despite we might have different definitions, I believe that most of you agree that these are common features of the system you would like to see. Why transformative primary healthcare is needed now more than ever? Let's look at the challenges that we are all facing in the future. We are getting older. Older people need more services. It means that our systems, if today are offering 3 to 4 consultations per capita, we might get into 10, 12 consultations per capita. Where are we going to receive this workload? Same for addressing NCDs. There is a lot of unmet needs related to NCDs. This means, again, doubling or tripling the workload of our systems. Where is this going to happen? We have the climate change challenge, which also brings back communicable diseases. We also are facing fiscal constraints in the future, actually in the present. That means efficiency, call for efficiency gains. How our system is going to be more efficient? Are we going to build the solutions on hospitals? Are these the more efficient ways that we have? And lastly, the people in 2024 is not the people of 1978. They are having they are more educated, they have more information, and they are more demanding. They access services in a different way. How are we going to set our systems in a way that is consistent with the new pattern? Let me bring some reflections on whether the region is progressing towards towards primary health care. We have more services, more people using the services that they need. Fantastic, good news. We move from the left to the right, but we are having more people experiencing financial hardship. And if we look at where the problem is outpatient medicines. It is in the primary healthcare setting. Do we have enough workers? This graph is a relationship between the SDG 3.1, 8.1, which is people having access to services, and the density of our health workers. Do we have enough health workers? Many countries in the region are struggling. Just without mention maldistribution, is just having the right numbers. But more provocatively, are we training the workforce that we need? This graph, which is from a country in the region, it shows the evolution of GPs and specialists. Are we training the people that we need to deliver the services in primary health care, where the volume will come from and where the volume should be? Are the info flows user-friendly? let's look at the number of parallel information systems that we have. Is it health worker friendly? And lastly, are people accessing services in the right place? This graph just shows the difference in the growth in the pattern of use, hospital versus primary care. More people and more growth happening in hospital settings. Is this sustainable? And if the systems can sustain, is this equitable? To turn a bit the tide and bring good news, I want to bring our distinguished panelists that are going to share with us really interesting reforms that are being tried and are being pushed in countries in the region. So let me start with Madame Rahayu Maksam, the Minister of State and the Ministry of Health Development Information of the Ministry of Health in Singapore. Singapore, since July 1st, 2023, has put together a very ambitious reform which tries to walk the talk on putting the effort of keeping people healthier at the core of the policy. Quite inspiring. And for that, we have Madame Maksam that can share more with us. Thank you very much. The floor is yours, Madam.
Thank you very much, Mr. Torres. Good morning, RD, Madam Chairperson, distinguished members. I'm very heartened here today to be sharing the platform with very esteemed panelists. I am going to share a little bit about what Singapore has been doing, and I will latch on to what Mr. Torres said earlier, because indeed in July 2023, we had launched what we call Healthier SG. It is basically a national movement, an effort to bring our people into an enrollment program where those above 40 are encouraged to enroll with a primary care provider, a GP, and this will be mostly in the private sectors. We do have 26 polyclinics, but for this effort, we needed to mobilize the whole of the primary care sector because we also have private sector GPs. So we now have about 1,000 over general practitioners in the space also on board in this program with us. Basically, there are a few features of this Healthier SG program. We want our residents to enroll with a GP who will then be able to know them, identify them, and have a baseline as to what their situation is. What we are seeing is that people go to the doctors when they are sick. What we want to do is to have people go to the doctor before they are sick so that they are able to then prevent diseases and take care of themselves. So with this, we are able to latch them on to GPs, and this is a key component. The GPs are usually located within their housing estate, the living areas. So these are people whom they know, whom they may have gone to in the past, and we then create a platform for them to be able to have that relationship, because once they sign on to the general practitioner, they will then be able to have a health plan. So this is another key feature of Healthier SG, where they have an individualized health plan that they come up with the general practitioner. With this health plan, we also connect to the community in that there can be recommendations and referrals to the community partners. So the other key element of this Healthier SG is the partnership with the community stakeholders. These are people in the community who organize programs, exercise programs, and other mental health and well-being programs in the community. If there are needs that they can offer, the services they can offer, and it's matched to the needs of the individuals, they are then matched through the general practitioner. The other key component of Healthier SG is the various benefits that they can get, because they get subsidized screening, and if they there's some recommended vaccinations, they are also eligible for that. Then these are all fully subsidized for them. So there is a component of a discount, and that encourages them as well to come on board. They are also latched onto the system, which allows for us to have a seamless flow of information from the primary care to the acute care, because how our healthcare system is structured is that we have regional healthcare systems which oversees a certain demography and a certain community. So with that, we have another key component and key feature of Healthier SG is the IT system, the infrastructure that needs to be present so that data can be put in, there is a proper tracking and proper referrals can be then made, facilitated by that. So this is a key feature of the Healthier SG program. So basically a few things. One is the enrollment, the individualized health plan, networking with the community partners and stakeholders to see what are the other programs in the communities, getting our GPs on board and having that IT system that works, that connects everything together. That is one key thing that we have. As just now Mr. Torres mentioned, it is also key to train and make sure that our team and people are tuned and clued in to this whole effort. So we needed to make sure that our primary care sector is also fully equipped to address and handle this issue. And we have been working on this. As I mentioned earlier, we have over 26 polyclinics, and we have actually 1,800 private clinics. So far, 1,000 of them have been enrolled in our Healthier SG process. But the primary care is still the key effort that we need to look at, aspect that we need to look at, because it is an important first line of care in our healthcare ecosystem and preventive and chronic care management. So we have also come up with a certain framework to look at transforming our primary care, and we look at it through 5 key aspects. There are 5 Ps to facilitate recollection. First, professionalism, because we want to raise the professional capabilities of the general practitioners so that they can manage complex cases within the communities, and we're investing in the competencies of the family doctors. They are already given training within their curriculum in their family medicine and preventive care courses, but there is continuing training through the College of Family Physicians Singapore and through the polyclinics. The second P is practice, because as the population ages, conditions become more complex and it's no longer sufficient for one doctor to deal with one problem. So we look at the work through teamlets. And in Singapore, we have the primary care networks where the different partners, different services can connect together to provide help and support to that individual. And the next P is partnerships. So we also ensure there's partnerships both upstream with the community, touch points within the community, as well as in the downstream through the hospitals and specialist centers, so that there's a flow of care for the individual. We also look at payments, because within especially the private sector, it is sometimes the bottom dollar that matters, and we want to make sure that this is something that is sustainable, workable for them. So actually through the Healthier SG program, we do have certain packages to the doctors that we give, so that once they enroll, there is a certain payment. And the last P is platforms, where we continue to emphasize the need for seamless data flow across the providers, and we have our national electronic health record, NEHR, that actually provides that platform. There's a lot to say in this short time. I'm happy to take questions later if there are any interest in the things that we're doing in Singapore. Thank you.
Thank you very much, Madam Maxam. I'm sure that in the coffee breaks, plenty of the colleagues will approach you to learn more. And one important feature also of Singapore Reform, the Healthier SG, is if you look at YouTube or TikTok or Instagram, there is plenty of material explaining what it is, even done by the minister himself. So thank you very much. Now let's move to the second panelist, His Excellency Dr. Low Bianakiri, which is the Secretary of State for Health in Cambodia. Cambodia has put a lot of thinking in recent times with the UHC roadmap, with the PHC implementation framework, and it's in a decentralized setting with powers being decentralized, given to the provinces. So Dr. Kiri, please, could you give us a bit of updates, challenges, and where are we now? Thank you.
Madam Chair, regional directors. Thank you for the opportunity to be share perspective with regard to the PAC transformation in Cambodia. First, let me highlight the snapshot or the background of the system reform in Cambodia. Because Cambodia, with the support of the WHO in 1993, we planned the health sector reforms. And then the reform has been put in place in 1995. So the reform objectives is to improve and expand the primary health care through the district-based health system approach. So in these reforms, we transforms both organizational structures of the health system and also the health financing systems in order to meet the essential health need of the populations, in particular also to build the trust of the population on the public health systems. And the result of the reforms, we have organize our system into three levels. The first level we call operational district. This is the two-tier system, which consists of the health center, which is the first line of the contract between the public health facility and the population in the community. And also the first referral level of the system is the district hospitals. So I think through this reform, we also had to enforce the role, the new role and the function of the health center and the district hospital, as well as the hospital across the different levels of care. We retrain and redistribute the human resources in order to meet the newly defined role and function of each level of care. And we also we embark the budgetary reform, which include improve the allocation of the resources, in particular financials and human resources. And also we initiate the new way to finance health services through the introduction of Cambodian health financing charters, which allow them ways to introduce the systematic health financing system, such as community-based insurance, user charges, and also develop the social health protection, or in other words, we call the social health insurance system SINDAN. And this, I think, so the health system reform in Cambodia is almost more than 30 years. And then so far, we have come up with a very good result in terms of delivery of the primaries and also primary services, in particular the health centers. Because the health center, we promote the integrated high quality, promoting, preventing, and basic curative health services. And also the service should be geographical, financial, and the cultural or culturally accepted by the community. And the health center also will promote the community engagements. And since the reform, we had establishment the health center management committee, which is led by the elect commune councils. And in this committee, we have the representative from the elite health support group, which is the gender-based based balance group. Because in each village, we select one male and females to be represented of the people in that village. So roughly in the catchment area health center, we have the 10,000 populations. So we have 10 to 15 village. So the village health support group, we selected from each village to be part of the health center management committee. So this committee had to be had the role to support the development and also to monitor the services provided by the health centers, and also the engagement in setting the fee levels, because the fee levels implemented at the health facility is to be go through the consultation process and agreed by the community before they send to the wage for final approvals. And for the primary health care, I think in order to reinforce the primary health care, the government has been introduced the priority programs which focus on expansion of the health services toward universal coverage recently. This will be based on two approaches. The first will be expanding the additional population coverage for the current social health protection. Because currently in Cambodia, we have two sizable social health protection system. The first one, the health fund for the poor family and also informal sectors for workers. And recently, we expand the coverage of the scheme to cover the vulnerable family, which is the people or the household who living just below the poverty line. And this group of the people are easily to falling down into the poverty if any shocks like we experienced from the COVID-19. And we also expand the other scheme with the National Social Health Security Fund for informal sector for both public and private. And recently we increase this expand this coverage of the scheme to cover the self-employed on a voluntary basis, and also to cover the independent or the civil servant and the private worker and employee, which is the compulsory and the contributory groups. And for the UHC, I think we also focus on the three dimensions of the UHC and the WHO frameworks. The first, population coverage, and also the second is the health coverage, and the last one is the financial coverage. So we have set a clear target for 2035 by the using more than half. By increase the coverage of the population more than half from the current baseline 42%, and also increase the UHC coverage index more than half from the current baseline 58%, and also reduce output occupancy from the 60% currently to less than 35%.
Thank you very much. Your Excellency, Dr. Kiri, very important, and the highlighting of the community engagements and also the health financing as the fundamental part, no? Creating the right incentives also to protect the most vulnerable. And probably these two aspects have a lot to do with the impressive progress of Cambodia on the MDG indicators that we have observed in the last couple of decades. And now let me turn with the last panelist of this Transforming Primary Healthcare panel. I want to invite Dr. Eduardo Banzon, he's the Director of Health in the Asian Development Bank, and a very important partner when it comes to support member states in primary healthcare reform. So I cannot call other than Dodo. Please, the floor is yours.
Thank you, Luis. And first of all, it's thanks for inviting me here, and my favorite UN agency, the World Health Organization. Also helps that I used to be a former WHO staff. Nonetheless, the world has changed. We have seen Asia transform for both bad and good. Cities has become huge. Asia is about 7 of the largest cities, most of in the world. We have seen roads, fast trains, rapid bus transits, low-cost airlines have made travel easy from rural to urban. Internet connectivity has exploded, enabling remote access, real-time data capture, analysis, virtual training. Devices and equipment has become portable and miniature. And of course, in Asia, the private sector has grown. in this Asia which is transforming before us and with us, we need primary healthcare to transform, to harness technology and the private sector, to further empower all types of human resources for health, from health professionals to community health workers, and as been said here in this meeting, to address climate change, to become climate resilience, and to mobilize, we are a bank, more money, all types of financing for primary care or primary health care. We are now seeing a lot of countries using both budget and national health insurance or some form of health fund to finance primary care. We're seeing this in Laos, PDR, Mongolia, Philippines, Vietnam, and of course soon our friends from Indonesia. So we now need to make sure that these different streams of financing for primary health care should not be fighting, but should become a virtuous cycle, harmoniously increasing financing for healthcare, budget leading to more health insurance payment leading to more budget. And of course, continuing to leverage this government money to do something that needs to be done in primary health care, make the private sector behave to make sure that they're supporting your objectives in primary health care. We also need to continue enhancing and nurturing resilient and inclusive community health workers. I think this debate of community health workers have to be done. Are there volunteers? Do they need to be paid? To what extent do we need to build their capacity? Because really, they need to be provided appropriate compensation for their service. At the same time, to be given skills because they are really your foot soldiers on the ground. Not only that, you also have to make sure that the best use of your health professionals. I always wondered, I'm a medical doctor, but why do I need to become the manager in the health system? Why can't other health professionals be one? At the same time, we need to make all health professionals understand primary care. I always enjoy when I talk with a neurosurgeon, or in the case of the Philippines, one of the best emergency trauma surgeons the Philippines have, Secretary Herbosa, talk and understand primary care. Because you always believe surgeons doesn't give care about primary care, they just want to slice. And we should, and in a sense, get all the health professionals to work together. You know, there should be, the silos have to be broken down among these health professionals, working together, like all WIPRO countries are working together to weave better health outcomes for all. We need to continue, and this is something we in ADB find very important. There's a lot of new technologies that are out there, point of care diagnostics, which will allow, in a sense, health workers don't tell the patients, you leave, you come back, you have your lab test 3 days after, things that deter access. There's a lot of point of care diagnostics, portable imaging, portable x-rays, portable ultrasounds. They should be adopted rapidly, making diagnostics easy for all people to access. We're seeing this in a lot of small programs, in TB programs. Why do they have to be just limited in pilot programs or, in a sense, vertically financed interventions when they could be part of all primary care systems? We need to make surgeries ambulatory. Okay, the idea that surgeries and procedures can only be done in an operating room in the hospitals, I think, is changing. The bukas of the Philippines, and we're also seeing this in other countries, technology has made it easy for these procedures to be done on a day ambulatory surgery basis, and this should become the norm. And as in the story of Singapore, we need to bring maternal and child care, NCDs, elderly care to the homes. It doesn't have to be done in the facilities. And this is why we in ADB are very excited, as I told our colleague here, the minister, that we're really closely watching what they're doing in Singapore. Because bringing NCD care in a world that we're aging to the homes is going to be crucial. We need to make treatment and surgeries easy for people to access. We also need to fully adopt a digital primary care. Let's not forget, we trust our money to QR codes. I could not use cash anymore in China or PRC, or even in the nice malls of Indonesia. We trust our money to ATMs. So why can't we trust our health data to the world of digital? Primary care should include discussions of clouds, big data, Starlink, if you want to work with Elon Musk, data capture, telemedicine, telediagnostic, interoperable systems. All this language, including AI, should be fully understood by people running primary care system, and they should be part and parcel of any transformative system. So I think we will work with WHO to make these terms not something nice to hear, always there being talked about by people, but really become part, integrated, incorporated in the system. And yes, as said, we need to make health promotion TikTok, Facebook, WeChat, Instagram, WhatsApp. I have to admit, I'm not in Instagram, but people get information from this or from social media. And I think you should, how do we call it, capture and make social media. And as we've seen the pandemic, they're very powerful platforms for us to talk about how to get people access in the pandemic. We need to increase investments, and we in ADB is here, ready, in climate resilience primary care facilities and HRH, particularly in the Pacific. Let us not forget, if climate change happens, climate change is now recognized as the biggest public health threat in the world and in Asia. The Pacific nations would be among those that will be most affected. And RD, we in ADB, we're actually going to work, we hope to work closely soon with your team in making your health systems in the Pacific with more climate resistance, and we look forward to further discussions. And you always say, COVID was the greatest public threat, the epidemic, right? We saw how our public health workers basically fought gallantly, and let's not forget, we won against the pandemic. So if we can beat a pandemic, climate change is easy to beat. Asia has transformed fast. For a lot of us, I'm not that old, but when I go around, I'm always so, every day is, you go to a country, Asia is just moving so fast, right? And soon I'm looking forward to the new airport in Cambodia. The only airport that is not improved will be in Manila, but it's okay. So you go around Asia, you go to the airports, everything is moving fast. The roads, fast trains, they're all over. And we believe that primary care should transform faster than how Asia is transforming. And Asia is changing because everybody's working together. So we look forward with the leadership of WHO in the health sector. Of course, we in ADB, we're ready to provide timely financing support to countries. We look forward to immediate government actions. At the end of the day, a lot of this is at the government level. We look forward to civil society and the private sector providing inputs. We look forward for great partnership as we have done in the pandemic. And if we do that, then this transformative primary healthcare vision that Luis is talking about will happen much faster than we ever imagined. Probably it will happen today. So thanks a lot.
Thank you. Thank you very much, Dodo, to get to the center of thinking about the models of care, about how we organize ourselves and this provocative thinking that we should most clearly faster, at least as fast as Asia is changing, if not faster. So we have finalized the panel, and now I would like to open the floor for member states that wish to intervene. And we have a hard stop at 12 to allow all delegates to have lunch before the investment round session starts at 12:50. So I would like then to start, and please be mindful about this hard stop. So first, if I can read properly, I would like to call the representative of the USA territories. The floor is yours, ma'am.
Hello? Okay. Sorry about that. The United States, thank you very much, Chair. The United States territories of American Samoa, Guam, and Northern Mariana Islands thank WHO WIPRO for its continued work to promote and advance transformative primary health care. The U.S. territories have long experienced challenges of having adequate primary care providers, even for its small populations. The islands are still classified as health professional shortage areas, HEPSA, by the Health Resources and Services Administration. In a financially constrained health system, primary care can help reduce the cost of referral and the need for specialty care. Effective primary care must be available, accessible, and affordable, so the health and well-being of individuals is achieved. Post-pandemic, the shortage of healthcare providers has significantly affected and altered the recruitment and retention strategies of health systems. The cost of financing this critical need for our population has become even more pronounced compared to pre-pandemic. We support financing reforms that are essential to improve the performance and efficiency of health systems and meet individuals' health needs at the primary care level. We also urge the removal of silos in funding for health systems. While we have funding for health prevention and promotion, it does not necessarily align with funding specifically for treatment. Hence, the continued struggle of NCDs for the health system. Like the woven mat, funding flexibility to weave the funds to meet the local needs can have strong impact. In addition, we urge sufficient funding, training, and acceptable licensure of community health workers, CHWs, to support and help bridge the gaps. CHWs promote health within our communities by offering education, navigating the health system, and advocating for the individual on their health issues. CHWs are a representation of the local workforce that embody the weaving of modern medicine and traditional health practices that assure cultural respect and provide an opportunity for provider-patient relationship. Lastly, having data modernization support and guidance on the use of acceptable AI platforms is also essential. Technical assistance can support member states in identifying the right solutions responsibly that are cost-effective and both patient and provider-friendly. In conclusion, we support the transformative primary care healthcare approach to advance health efforts towards achieving health equity and addressing health disparities and consideration of member states' uniqueness and challenges while identifying and supporting best practices accordingly. Thank you.
Thank you very much, USA Territories. Now I'll give the floor to Fiji.
Thank you, panel moderator, distinguished panelists, honorable members of the forum. May I begin by congratulating you, RD, and the Secretariat for a very enjoyable alcohol-free dinner evening last night. I thank the panelists for the rich discussion on transformative primary health care. Transformation of PHC in Fiji requires a shift towards a new fit-for-purpose model of healthcare. Health outcome indicators in Fiji and assessments on our primary healthcare systems have signaled the need to transform primary healthcare in order to improve comprehensive health services access, quality and equity of care, and prevent spiraling healthcare costs. Proactive care has the potential to reduce total hospitalization, avoid admissions, and emergency care. We believe that through key investments in community-based, person-centered, and quality care, key health outcomes like longer life expectancy and healthy life expectancy can be shifted to be on par with neighboring developed countries in our region. In alignment to the new regional vision of weaving health for all, and the regional framework on the future of PHC in the Western Pacific, the Ministry of Health in Fiji, with the support of WHO and in consultation with other government agencies, stakeholders, and community groups, is developing a 20-year primary healthcare roadmap for this transformation. This will be through proactive and intentional actions with stronger prevention, promotion, treatment, and better access to quality medicines, treatment, and equipment at the first point of care access for our people using digital health and data for planning and cost corrections. Already, and through generous support of our donors and partners, we are upgrading infrastructure at the most needed facilities. We are working on building a stronger, resilient, and sustainable health system and strengthening PHC governance and leadership. Through our advocacy and commitment and collaboration with with our stakeholders, development partners, primary sector, community-based and faith-based organizations, we will establish a multi-sector coordination mechanism with strong government support. We are prioritizing patient care, patient satisfaction as a measure of quality service by engaging customer service officers at our main hospitals. And we are also strengthening our community engagement. Population health and facility management are important components. And we have also decentralized budgets to enable subnational level managers more efficient processes. The transformation also involves better care continuity and care pathways from screening, treatment, and referral from and back and into the community. Fiji is committed to reducing challenges relating to NCDs and increasing our comprehensive health services quality. We are in the process of developing our 10-year workforce strategy and setting the stage for healthcare services by establishing our essential service package and reviewing the role delineation policy and essential medicines list. This transformation is a comprehensive journey, and we look forward to the ongoing support of WHO and our partners towards this effort. I thank you.
Thank you very much, Fiji. I call on representative of the Cook Islands.
Thank you, moderator and panelist members. In February this year, the Cook Islands government endorsed the National Healthcare Reorientation Plan 2024+. The purpose of this plan is to transform the existing curative primary healthcare system to an integrated people-centered health system that prioritizes people's health and well-being. This transformation involves increased focus on prevention, where the provision of care is proactive rather than reactive, comprehensive and streamlined early detection and early intervention. The plan also provides a new model of care we call the Kupenga model. A Kupenga is an open weaved net used for fishing. Like a fishing net, the size of the net determines what it captures, placed at the bottom of each tier of the model. In the context of this model, we use the net metaphor to refer not to catch fish, but to catch the 5,800 individuals, which accounts for 52% of our population over 15 years of age, with various degrees of illness from mild to severe comorbidities and chronic conditions, who are at risk of falling through the net. The seriousness or severity of their conditions and their CVRA rating determines where they sit in the model, or how far they may fall through the net. A project to color code patients in our patient information system is underway for quick reference for triage nurses and clinicians for appropriate interventions, care, and support. It is a 4-tier funnel model with the aim to reduce the number of admissions and premature deaths caused by uncontrolled levels of NCD, with the ultimate goal to empower individuals to promote healthier lives through constant self-testing, screening, the Healthy Islands, Smoke-Free Islands, Healthy Schools, Baby Teeth Matters initiatives, and other initiatives as we transform our primary healthcare services to achieve universal health coverage. 2 weeks ago, we have reopened the Puna Ora-Tumanawa Primary Healthcare of Excellence after 4 months of renovation, as we integrate oral health, family dietary, NCD, mental health, and tobacco cessation counseling being integrated at primary healthcare setting. During COVID-19, we integrated the centralized primary healthcare services into the villages. As we also increase our partnership with our private GPs and NGOs through an arrangement of cooperation for direct support and access to health patient information, preventative and home care management for quicker intervention. We will soon be relocating public health nurses in primary healthcare community clinics. Since launching the Healthy Schools for the southern part of the Cook Islands, the initiative proved to indicate significant improvements to students' oral health caries and slight reductions in the level of overweight and obese children from the initial screening of schools in 2023. More follow-ups is currently underway. Our transformative efforts will continue to progressively achieve UHC and SDGs in the Cook Islands by 2025 to 2030. I therefore acknowledge all development partners, WHO, UNICEF, SPC, FAO, and the private sector businesses the Bank of the South Pacific for their support to our transformative efforts. The Cook Islands supports the transformative primary health care for UHC framework. Your Honor, I thank you.
Thank you very much, the Cook Islands. Now I'll like to give the floor to Marshall Islands.
Excellencies, distinguished guests, esteemed colleagues, Madam Chair, all protocols observed. I wish to extend my heartfelt gratitude to the panelists for sharing their invaluable experiences on this agenda item. Your insights have really enriched our discussions and will inspire us to strive for a healthier future. Excellencies, the Republic of the Marshall Islands supports and recognizes that transformative PHC is crucial for realizing our collective health aspirations. Central to our approach is Kumidi Ejimur, which translates to health is a shared responsibility. This principle emphasizes that healthcare is not just a service, but a partnership involving our government, communities, and individuals. This year, we proudly launched our Clinic Without Walls. This initiative brings healthcare directly into our remote communities, ensuring that no one is left behind. This effort is about saving lives, restoring dignity, and fostering belonging to us all. We are also actively monitoring our ministry's strategic plan, aligning with the National Strategic Plan to address that evolving health needs of our communities is important. Additionally, we are excited to introduce our first Health in Our Policies initiative, where this collaboration with our Parliament aims to integrate health considerations across sectors, ensuring that health remains central to the national development. Transformative PHC means creating a health system that is comprehensive, equitable, and resilient. The RMI is in creating preventative care, NCD management, and maternal health services, while collaborating with sectors focused on climate resilience to address broader health challenges. Excellencies, success is not measured solely by the statistics, but by the trust we build with our communities. The relief a mother feels when she accesses care for her child, and the peace of mind for families no longer needing to travel long distances for basic services. Through Kumudi Ejimur, we envision a system where every person in every village on every island can claim their right to good health. This is a transformative primary health care. It is a collective responsibility fueled by our commitment to each other. RMI remains committed to advancing transformative PHC as the cornerstone of our journey towards universal health coverage and sustainable health system. We are honored to stand in solidarity with our regional partners and our neighbors to build healthier, more resilient societies. Thank you and komoltada.
Thank you very much, the Marshall Islands. And I call on the representatives of Australia.
Thank you, Chair. And I'd also like to thank the panel for sharing valuable experiences and insights, and also to the Secretariat for providing us the opportunity to discuss primary care and its vital role in progress against achieving universal health coverage. Australia appreciates the strong recognition in the endorsed regional vision on the importance of building and maintaining robust, resilient, and sustainable health systems centred on primary health care, and that accelerating efforts to realign primary health care is critical to achieving UHC and ensuring progress against Sustainable Development Goal 3. Australia's health system is founded on the principles of UHC through the provision of universal access to quality services, supported by Medicare, the Pharmaceutical Benefit Scheme, and the aged care system. Australia's reforms are committed to providing integrated, person-centred primary care. The transformative primary healthcare approach is fundamentally about reorienting health systems to prevention and early intervention. This is integral to building and maintaining a quality healthcare system that can withstand increasing pressures. Australia considers it vital that we all invest more and better on primary healthcare to avoid backsliding on pre-COVID-19 health gains. One strategic entry point for tackling the primary healthcare transformation outlined in the framework is through targeting health investments. This could be to areas where early intervention can reduce downstream costs, such as avoidable hospital admissions. Through being able to demonstrate that accessible, affordable, and quality primary healthcare reduces costs, as well as improves health outcomes, we can establish the drive for whole of health system transformation. As part of Australia's work on primary healthcare reform, we have committed to establish 50 Medicare urgent care clinics across Australia to ease pressures on emergency departments. We look forward to continued discussions on this as the region to uphold our ongoing political commitment to advancing primary healthcare. Thank you.
Thank you, Australia. Now I'll call on the representative of Brunei Darussalam.
Bismillahirrahmanirrahim. Thank you, Chair. Brunei Darussalam's primary healthcare services are provided through strategically located health centers and clinics, ensuring accessibility for our citizens. Furthermore, primary healthcare strategic is to ensure continuity of care, especially for those with chronic conditions, through care by a consistent team of health professionals, as this will foster better patient care, communication, and trust. Innovation is in the heart of our approach. Our Brunei Health Information System, we call BruHIMS, is a one patient, one record throughout the government healthcare system. Support this by providing a unified health records for each patient, thus enabling coordinated care. The COVID-19 pandemic has expedited Brunei Darussalam's plan towards a one-platform digital health for public and private healthcare providers. Now, our BruHealth application has transformed and empowered users to manage their health records, schedule appointments, and access to healthcare telehealth services. This digital shift is crucial, especially as we introduce the management of chronic diseases through personalized platform. Brunei Darussalam is facing an effect of global phenomenon of population aging and increase in non-communicable diseases. And the primary healthcare setting is the most conducive setting to implement preventive and promotive initiatives. To this effect, the National Health Screening Program has been implemented to increase detection of NCDs, including on colorectal cancer, breast cancer, and cardiovascular diseases, and access to program is possible via self-assessment in the BruHealth application mentioned earlier. In fact, since the launch of the breast cancer self-risk assessment on the apps, over 3,000 users has been identified as eligible for mammogram, with over 20% been booked for mammogram via apps. We were also implementing revised protocol on cervical cancer screening, including the use of self-sampling for HPV tests, and as well as the use of AI for diabetic retinopathy screening. Additionally, our primary healthcare services also places a strong emphasis on quality improvement activities through audits and issuance of standards operating procedures and clinical guidelines, as sharing this with private healthcare providers to ensure evidence-based care are given to all. Further research is needed to support, understand, and improve the extent of strengthening the primary healthcare in Brunei Darussalam, and we welcome the sharing of experiences from other member states in this agenda. Thank you, Chair.
Thank you very much, Brunei Darussalam, and I'll give now the floor back to the Chair.
Thank you very much. Honorable delegates, it is so great to see such enthusiasm for the panel discussions this week. And I would like to ensure you will all get the chance to make your statements. So please bear with us as we move a few things around in the program, so we are flexible. So now we will suspend this item and we will go for our lunch break. After lunch, we will come back and go straight on to item 15.5A, Indonesia's request. Following that, we will resume discussion on item 8, the program budget. And then after, we will resume panel discussion on transformative primary health care to take the final remaining statements. Given we finish the formal program at 4 p.m. today, to make way for a side event on tobacco control, we will take up health financing tomorrow. So before we break for lunch, may I remind the committee that there will be a side event on investment round at 12:50 here at the plenary hall. And after the investment round, we will reconvene here at 2 p.m. to take up item 15.5A on Indonesia's request. I thank you and see you all here for the investment round at 12:50. Thank you very much.